Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. This time to wrap up the ESC 2024 Congress. My name is Nicolas from Mieghem, and as always, I do the wrap-up and the previews with my good friend and colleague Joost Daemen. Joost, it was quite an exciting meeting, a lot of science.
Absolutely, as typically for the ESC, a lot of interesting stuff. And we selected at least these trials that we thought could be of interest. And we want to start with the structural space. And the first trial that we wanted to highlight is the RESHAPE-HF2 trial.
Yeah, so there are a lot of excitement around RESHAPE-HF2. As you remember, this was a multi-center trial in Europe that started in 2015 and took all the way to 2022 to get 505 patients enrolled. They were looking for patients with HFrEF, heart failure reduced ejection fraction, and secondary mitral regurgitation. Patients were then randomized to standard of care or TEER, transcatheter edge-to-edge repair with MitraClip on top of standard of care. The primary endpoint was a composite of recurrent heart failure hospitalizations and cardiovascular death within 24 months. The co-primary endpoint, total heart failure hospitalizations at 2 years, and then a third primary endpoint was the KCCQ, quality of life assessment at 1 year. The question up front, are we looking at another COAPT trial or would this be more similar to the MITRA-FR? Well, first of all, if you look at the first primary endpoint, and again, it's the rate of first or recurrent hospitalization for heart failure or cardiovascular death. We're talking about 37 events per 100 patient years in the device group versus 59 events per 100 patient years in the control group. This was statistically significant in favor of the TEER treatment strategy. The same thing could be seen for the primary endpoint of first or recurrent heart failure hospitalizations, 27 versus 46%. And then also looking at the KCCQ, there was an increase of a mean of 21 points in the device group versus only 8 points in the control arm. So this was all very significant and at first glance looks quite similar to the COAPT. And if you look at the patient characteristics, also some similarities. If you look at left ventricular and diastolic dimensions in terms of volumes, the volume of around 200 mLs corresponds to the 190 mLs in the COAPT study. So there was a lot to do about the interpretation of the trial. The study investigators, Stefan Anker and Professor van Baardelebe, they were very excited and they were like really bringing it as this is really changing the guidelines. Well, I think there are also some limitations. Multiple sub-analyses were simultaneously published in the Journal of the American College of Cardiology. The main paper was published in the New England Journal of Medicine. What were the major limitations? I think one of them was that the trial design had changed over time. And obviously when the primary endpoint changes, you always have to be careful with the interpretation of the end results. Secondly, it took a long time to enroll the patients. And at the end of the day, there were less than 2 patients per site per year included in the trial. So this is an enormous selection bias. Also of note, 23% of the patients in RESHAPE-HF2 had an EROA of less than 20 millimeters square. But that was a little bit strange because we were looking at patients with moderate to severe or severe MR. And if the EROA is less than 20, this is less than moderate or at best moderate mitral regurgitation. But you have to bear in mind, and I think this was one of the strengths of the study, that the core lab was not only addressing the transthoracic echo, like they were doing in COAPT and in MITRA-FR, but they were also looking at the TEE. And I think this integrated approach is very powerful. So looking at subgroup analyses of RESHAPE-HF2, it turns out that also the patients with more advanced mitral regurgitation, moderate to severe or severe, those were the patients that were benefiting for treatment. The patients with low or medium term mitral regurgitation, their benefit was not as pronounced. As a matter of fact, there was not a significant difference between the control arm and those patients. So I think at the end of the day, as long as the patient has more than moderate mitral regurgitation on top of HFrEF, those patients should be considered for transcatheter edge-to-edge repair. I don't think we should be dogmatic and say, well, all the patients with moderate or more than moderate MR qualify now with for a TEER when they have HFrEF. I think that is too early for that. We need much more well-designed, proper randomized controlled studies. I think this is still the beginning, and obviously the ReShape-HF2 has fundamental limitations. So this is definitely not a trial that will change the landscape, but it is a good thing that it is more COAPT-like than MATTERHORN-like. And we definitely also recognize the patients in our own practice who are on all the heart failure meds and then still are symptomatic and have more than moderate MR. Well, those patients, they will do very well in general with a TEER treatment.
Absolutely, and then with a relative reduction in the primary endpoint of CV death and rehospitalization of 36%, I think it's a strong sign, and as you say, very much COAPT-alike. So I think a good thing for TEER, but there was more on edge-to-edge repair.
Yeah, there was MATTERHORN, and MATTERHORN is another interesting study from Germany. 210 patients were randomized to MitraClip, TEER, or surgery. And surgery could be repair or replacement. The study also started in 2015 and it took 7 years to enroll all the patients. The primary efficacy endpoint was a composite of death, hospitalization for heart failure, mitral valve reintervention, implantation of an assist device, or stroke within 1 year after the procedure. And it occurred in 16% of the patients with TEER versus 22% of the patients in the surgery group. So this was statistically significant in terms of non-inferiority. So TEER was non-inferior to surgery. And if we then look at the primary safety endpoint, which was a composite of major adverse events within 30 days after the procedure, this occurred in 15% of the TEER patients, and as expected was much higher in the surgery arm, up to 55% of the surgical arm had a bleeding event. After 30 days, and this is notable, there was no difference in safety events between the two treatment arms. The recurrence of moderate to severe MR happened in 7 patients, 7 out of 79 patients with follow-up data in the TEER arm versus only 1 of 65 patients in the surgery arm. After TEER, also in terms of MR reduction, 3.7% of the patients still had an MR grade 3+, a quarter of the patients had an MR 2+, and 73% had no or mild MR. This compares to the surgical arm. 87% of the patients had no or mild MR versus 11% with moderate and 1.4% with more than moderate MR. So this is totally within what we were expecting. So surgery will basically take better care of the mitral regurgitation. At the same time, TEER is becoming better and better because we are multiple generations of TEER devices, of MitraClip devices were involved in the study. But there were other issues, as apart from more bleedings with surgery, there were also numerically more strokes in the surgery arm versus 0 with the TEER arm, and also looking at atrial fibrillation, obviously more common with the more invasive procedure that surgery still is, 28% versus only 3% with TEER. And I think to conclude, in patients with secondary MR, there is no hard guideline that recommends surgery. And now we also have a randomized controlled study that shows that in terms of safety, it's better to proceed with TEER, and in terms of efficacy, it is non-inferior to do TEER as compared to surgery. I think the interesting comparison is the comparison with the EVEREST-2 randomized controlled study. Remember, 15 years ago, the TEER was not non-inferior to surgery, but the interesting part there was that also moderate MR was part of the primary endpoint. So if they would have included moderate MR in the primary endpoint, probably also MATTERHORN would have been a negative study. But now, because of the primary endpoint in MATTERHORN that did not look at moderate MR, it became a positive study. I think that gives you the perspective of how important primary endpoints are, how the definition of the primary endpoint determines the end result of the study. And it's also difficult then one-to-one to compare Matterhorn with Everest. It's just too easy and too simplistic to say Matterhorn is a positive study and Everest was a negative study. I think you have to really look into the primary endpoints of the two different trials, and then you will see that basically both studies are saying more or less the same thing, that TEER works in patients with secondary MR, and it is a very safe procedure. Also of note, Everest was predominantly patients with degenerative mitral regurgitation, so you would expect also somewhat different outcomes in terms of moderate MR. But let's make it not too complex. TEER is a very good option for patients with HFrEF and secondary MR.
Absolutely. And again, just to make one small comment, as you already noted, this trial started in 2015, and I think we made great progress with the multiple new varieties of the devices that we're currently using. And
only gets better.
It only gets better. So I think these results are very promising and favoring a percutaneous strategy.
Tri.fr. This was a study that was focusing on tricuspid TEER, and we already had one randomized study that was published in the New England a couple of years ago, Triluminate. This time, this is the French study looking at tricuspid TEER with TriClip for symptomatic secondary tricuspid regurgitation. Patients were turned down for surgery by multidisciplinary heart team, and the severity was confirmed by an echo core lab and the screening committee. The study was run in France and Belgium, and the primary endpoint was this composite score that classifies a patient either as improved, worsened, or unchanged. And this was a composite of functional class, New York Heart class, quality of life assessment, and major cardiovascular events being mortality and hospitalizations. So looking at TR less than grade 4 at 1 year, this was achieved in 46% of the patients in the control arm versus 93% in the TEER arm. So TEER was very effective in reducing severe, massive, or torrential TR to less than severe TR. And this was a highly significant benefit of TEER, obviously well known also from the Triluminate. Similar to Triluminate, the KCCQ at 1 year was better in the TEER arm. It was, the KCCQ overall score was 70% for the TEER arm versus only 55% for the control arm. But then again, there was no effect on mortality or heart failure admissions. And this basically is almost a copy of the Triluminate. And there was a lot of debate among panelists, but also at the ESC in general, whether this data is good enough to justify a guideline recommendation for tricuspid TEER with patients with secondary tricuspid regurgitation. In my personal opinion, my humble opinion, yes, I would say yes, because the quality of life is a very important item from a patient perspective. And patients will improve their quality of life. You may not prolong their life, but at least you would keep them better, with a better quality of life. I think that is an important asset. The question is at what price, and I think this cost effectiveness analysis will become very important.
Yeah, I agree. I think this is not mitral, right? This is tricuspid, and the results are simply less striking, less positive, and you can say, okay, quality of life is better, but conversely, this is not a sham controlled trial, right? This is open label. There's no difference in heart failure admissions. I think more data is needed, and how we should get that, I'm not sure, but it's somewhat more difficult, I think, than the mitral space.
Well, there's a big one coming up. We have Tricent that will be presented at TCT this year, and that looks at tricuspid valve replacement with the Evoque system versus control, and that obviously will not only lower the TR to less than severe, but it will eliminate the TR, and maybe that will also then generate into heart clinical endpoints or a reduction in heart clinical endpoints, but that will be discussed and presented at TCT later in Washington this year. But now let's switch from the structural space to the coronaries, and maybe first a CABG trial.
Yeah, so a lot of interesting PCI and coronary stuff as well. And the first trial that we wanted to highlight is the SWEDEGRAFT trial. So as mentioned, this is a multi-center, again, pragmatic registry controlled trial, as we know from the Scandinavian countries. In this case, again, presented by Stefan James, so a randomized trial from Sweden and Finland, designed to investigate if a vein graft harvesting with the so-called no-touch technique is superior to a conventional technique in terms of graft patency at 2 years. So finally, 900 patients were randomized 1-to-1 with a primary endpoint of graft patency assessed with a CTA assessment at 2 years. And what the authors or the investigators found in the primary endpoint is that saphenous vein graft failure occurred in 19.8% of the patients in which the vein grafts were harvested with a no-touch technique versus 24% in the conventional arm with a p-value of 0.15, thereby not showing any clear statistically significant difference at a median of 3.5 years. So primary endpoint not met, although what the authors found, two more interesting findings in terms of clinical events, so MACE in this case, at a mean of 4.4 years, also statistically similar, 12.6 versus 9.9%. However, what they did find was 11% more leg complications and wound complications in those patients that underwent the no-touch technique. And strikingly, even at 2 years, 50% of patients still had leg-related problems in the no-touch technique versus still 24% in the conventional arm. So all in all, no clear benefit of the no-touch technique, and with that, this is a technique that likely should not be advocated in contemporary revascularization guidelines. And second, I think this to me, with 24% events in the, or 13% MACE in the vein graft arm, something that could also call for perhaps more PCI in the patients that may require vein grafts and are not eligible for arterial grafting.
Well, let's be honest. I mean, saphenous vein grafts are not going away anytime soon, and it is still the preferred grafting procedure for non-LED vessels.
Absolutely.
And at the same time, I think this persistent issues after the vein graft harvesting, out to 2 years, that is a concern. And
one out of 4 recruits.
I mean, it's yeah, but then also the leg issues that people have discomfort 25%. Because of this new technique. So this is to me yet another surgical technique that is not going to be adopted in mainstream practice and should not be adopted in mainstream practice. Let's just touch the veins when you try to harvest them.
Yeah.
Okay, so let's go to the cath lab again.
Yeah, so one of the trials that I looked out for perhaps the most was the OCCUPI trial. So a large multi-center Korean randomized controlled trial to assess the superiority of OCT versus angio-guided PCI in complex coronary artery lesions. As mentioned in our preview, a design very much CHIP IVUS-alike and improve. So 1,600 patients that were randomized if they presented with acute MI, CTOs, long lesions, bifurcations, left main disease, etc., to either angio or OCT guided PCI. At the end, so 1,600 patients, average age 64 years, 1 out of 3 patients had diabetes, and about 50% presented with stable symptoms. So 50% had ACS. As mentioned, procedurally, OCT resulted in larger stents, more post-dilatation, larger stent areas, but also significantly more contrast. And then the primary endpoint. So again, please remember, this is the first large-scale randomized controlled trial next to Illumian that now assessed the efficacy of OCT in overall complex lesions. Was tremendously positive. So the primary endpoint included CV death, MI, stent thrombosis, and TVR at 1 year, which eventually occurred in 4.6% of the patients in the OCT arm versus 7.4% in the angio-guided PCR arm. So a statistically significant benefit of 38% in terms of lowering the rate of the primary endpoint due to significantly less target vessel MIs and target vessel revascularizations. So important data for OCT, at least as used in this Korean setting. Subgroup analysis, two interesting analyses. One was the analysis on optimal versus non-optimal PCI, in which in this trial, again, a striking benefit was found in those patients who actually underwent optimal stenting. 77% less events as compared to those in the OCT guided arm who did not meet the optimal stenting criteria. So that again is a call to use imaging, but also to use it properly and to really do an attempt to do your post-PCI assessment to check for optimal stenting criteria. Moreover, in all the subgroup analysis, very consistent findings with no heterogeneity in the subgroups. And that, as anticipated, led to a lot of debate, specifically in light of the new revascularization guidelines or CCS guidelines that were released during this ESC. So just released, just prior to our wrap up, but just two striking findings we already wanted to highlight. First was the overall upgrade of imaging guided PCI with all the randomized data that we've seen over the past decade. Now finally to a 1A recommendation in patients presenting with complex lesions. So that's a very important update in the new guidelines. And second, a little bit outside the scope of imaging, also an upgrade of QFR, so the angio-based platform of METIS, to a level of evidence A, class of recommendation 1. So 1A recommendation also for QFR for patients presenting with intermediate lesions in the absence of pre-procedural ischemia detection. So also a striking recommendation in my perspective, given the fact that this was merely based on one Chinese trial that now finally led to a 1A recommendation, whereas the other alternatives being MUFR, AngioFFR, VFFR, and even RFR and DPR, being IFR alternatives, now downgraded to 2B, level of evidence C. So interesting observations in terms of recommendations for imaging and physiology in the new guidelines, but definitely something to dwell into in the near future, what this may entail in your routine practice. But for imaging, I think this is long awaited, long anticipated, and now finally there, so this will be a strong one.
Yeah, so one step back to the OCCUPI OCT, I don't think that the findings were unexpected.
No.
I think what also is important is that you need to try to optimize your end result, your stent result. And if you are not able to optimize, or you're not responding, or you're not being triggered by the OCT, then that will affect the outcome. And I think this is quite powerful. So we as operators need to become very familiar, and we need to become experts in the interpretation of imaging in general and OCT in particular for this trial. And I think what the guidelines claim now to recommend, highly recommend invasive imaging, not just OCT, but also intravascular ultrasound. That makes total sense, and this really also reflects our practice here in the Thoraxcenter.
Absolutely. Some more interesting data also from Asia was presented in the REC-CAGEFREE 1 trial. So a large randomized controlled non-inferiority trial from China, designed to assess the non-inferiority of rock-coated balloons versus drug-eluting stents in patients with de novo coronary artery lesions. So in particularly non-complex lesions, de novo. So this is the first real-world large-scale randomized controlled trial comparing DCB versus DES in patients not presenting with in-stent restenosis.
Was this a Chinese study? Because an old suspect of us was also involved,
Absolutely.
right?
Our big friend Patrick Savoyes was one of their key advisors, and had obviously a prominent role within the design and review of the trial. So an important one, 2,272 patients from 43 Chinese sites that presented either with stable or unstable angina and non-complex coronary artery lesions could be included. The DCB of choice, as mentioned, was the SWEDEGRAFT paclitaxel-coated balloon, Shanghai technology, not available in Europe as far as I know. A trial with, at the end, 27% diabetes, approximately half of the patients presenting with stable disease, an average of 1.1 lesion per patient. So first of interest, 10%, 9.6% received rescue DES because of unsatisfactory pre-dilatation result. And so before the DCB. And then the primary endpoint was a device-oriented composite endpoint at 2 years, which finally occurred in 6.4% of the DCB patients versus 3.4% in the DES patient. And with that, the trial just missed its non-inferiority margin, which was set at 2.7%. So with that, a negative trial not favoring the use of DCB in an overall population of patients with non-complex de novo coronary artery lesions. Looking into the subgroups, CV death, not statistically significant, but somewhat higher as anticipated in the DCB arm, 2.3 versus 1.2%. And clinically driven target lesion revasc, obviously statistically significantly higher, 3 times as high in the DCB arm as compared to the DES arm. So as mentioned, an important trial since this is the first large RCT of DCB in patients with de novo lesions. And I think we can conclude that DCBs, at least with this particular device, does not represent a valuable alternative for contemporary DES in patients with de novo lesions and non-complex disease. 2 comments. First, IV imaging used in 10% of the patients. I think that is something, although this was non-complex disease, is something that is interesting, specifically if you have a technology that you only recommend if proper lesion preparation was performed. I really doubt that this is something you can properly say based on angio alone. So this is something that may change the way we use DCB in the future. And secondly, although not in the conclusion of the main paper, there was significant heterogeneity of the treatment effect in patients with small vessels, in which DCBs could represent a valuable alternative. So clearly a better result with DCB in terms of non-inferiority in the smaller vessels versus those with larger vessels. So with that, I think more to come on DCB, specifically with the also discussion that was raised on DAPT duration with a trend towards lower bleeding risk in patients with the DCB.
Yeah, well, I would argue that an invasive imaging would solve the matter here. As we just discussed, the guidelines, the updated ESC guidelines recommend systematic invasive imaging in complex lesions.
Absolutely.
This trial was specifically focusing on non-complex lesions, and still there was no signal of benefit. It was not non-inferior to use a drug-coated balloon versus conventional PCI, and also 10% of the treatment arm ended up with a stent. So I think this is a very important trial because it pictures a more sobering reality, and DCB is not going to replace the current generation drug-eluting stents, and DCB, we have to be very careful that it doesn't become a BRS story, because this is not ready for prime time to be used in all comers. There might be selected sets of patients, as you mentioned, the small vessels, maybe also some of the in-stent restenosis patients that might benefit, but not all comers. And I think this is the important takeaway, and this is not going to change with implementing 100% intravascular imaging. I don't buy that.
No, with that I totally agree. I totally agree, and I think it's a call to those who have been advocating the use of DCB in large vessels, proximal RCAs, wherever
hold your horses.
They're pleased to hold your horses based on these results. More on coronaries was the SENIOR-RITA trial, so a multi-center randomized controlled trial from UK and Scotland, designed to compare an invasive versus a conservative approach in terms of proceeding with early stage coronary angiography and or PCI in those who are 75 years of age or older presenting with non-STEMI. So this was a trial presented by Vijay Kunadian, who finally managed to enroll over 1,500 patients with a mean age of 82 years old, 60% had cognitive impairment, and 80% was either pre-frail or frail. And despite that, underwent 90% of the patients in the invasive arm actually underwent angiography, and out of those 50% actually underwent a revascularization. I think that's an important nuance in the trial, because it's only those patients that could potentially benefit from an early invasive strategy, right? Because those who underwent just an angio, that will not do anything to the primary endpoint, which was set at CV death or non-fatal MI. We anticipated a little bit on the results of this trial, anticipated this trial should be positive, and that's also what the investigators anticipated. But in reality, what happened is that in these frail patients, mortality rates were high, and the primary endpoint of CV death and non-fatal MI was actually identical between both arms. So 25.6% versus 26.3%, obviously not statistically different at a median of 4 years. However, what the investigators did observe was a clear reduction in the occurrence of non-fatal MI and subsequent revascularization rates, which was clearly lower in those patients who underwent an early invasive strategy. So with that, a negative trial not supporting the, let's say, effect of angio and or PCI in reducing CV death or MI in elderly patients presenting with ACS, but a trial that also again showed that PCI is safe and significantly lowers the risk of MI and repeat revascularization. So with that, I think there is a call to be for perhaps somewhat more scrutiny in terms of deciding on a final treatment strategy in patients that are 75 years of age or older, in which we also look at frailty and overall condition of the patient.
Well, let's use some common sense here. The mean age was 82 years old, and then cognitive impairment is 60%. 80% were frail or pre-frail. So this is really an elderly patient population with a life expectancy that is not 10 years anymore, not even 5 years.
Exactly.
I mean, the life expectancy of a patient of 82 years old without comorbidities is around 4 years. Now, these are patients that have quite some comorbidities. Look at the frailty, look at the cognitive impairment, and on top of that, they have now proven cardiovascular disease because they had an MI. So I'm not surprised that we don't see any benefit in terms of these very hard clinical endpoints being myocardial infarction and mortality. As a matter of fact, as you mentioned, one in four, a quarter of the patients will die anyhow. I mean, that is what you can expect. That is physiology, that is normal. So I think the important message here is that you will reduce the need for re-interventions, and you will avoid that patients are rushed into a hospital for another intervention because of an ACS or whatnot. So I think this is a quality of life that you will improve in the remaining years of a patient's life. I think this is very important. So I would be very cautious by over-interpreting this as saying, well, just give medical therapy to elderly patients. No, this cannot be the conclusion of this trial. But this is an important study, but really try to understand what the background is of the patients that were enrolled in this study and what you reasonably can get out of a PCI treatment.
In patients like this, exactly.
Yes, you're not going to prolong life, but you will keep them out of the hospital and you may improve their quality of life, and that was not assessed in the study, but that is, I think, the important question in these patients.
Absolutely. So all nuances also for this trial in the New England Journal of Medicine.
EARTH-STEMI.
EARTH-STEMI is the let's say, last trial in the coronary space that we wanted to discuss. So Gianluca Campo, as mentioned, presented a meta-analysis on individual patient-level data from the FIRE, Compare Acute, Dynamic Multi, Culprit and Complete trial to assess the benefit of complete revascularization in patients presenting with STEMI, being 75 years of age or older and multivessel disease. So a little bit in line with SENIOR-RITA, but in this case really focus in those patients that were already scheduled for revascularization with the question, should that be done completely or should we focus on the culprit only?
And STEMI patients.
In patients presenting with STEMI.
SENIOR-RITA was non-STEMI.
Yeah, no, SENIOR-RITA was absolutely non-STEMIs. So we anticipated also for this trial a positive outcome because there was basically, as far as we knew, no heterogeneity in the treatment effect with age in any of these trials. And that's exactly what the investigators finally concluded in the composite primary endpoint of all-cause mortality, repeat MI and ischemia-driven revascularization. A significant 22% benefit was seen in terms of a relative risk reduction in the primary endpoint favoring the complete revascularization arm. Driven by a 24% reduction in CV death or MI. So again, nothing new, but I think a nicely done job in a meta-analysis that is now available online in circulation.
And again, we're talking here about elderly patients. Yeah. Well, I don't know what the mean age was in this patient population.
I'm not quite sure.
But this was a positive trial, and this makes clinical sense, right? So even if there was no reduction there would not have been a reduction in cardiovascular death, I think at least what this trial tells us is that you need to try to achieve complete revascularization. Don't be minimalistic. I think if you have a very good octogenarian who is active in life, who is participating in social interactions and whatnot, go for revascularization. Absolutely. Whether it's a non-STEMI, a STEMI, and also try to achieve complete revascularization.
Yeah. So, switch back to the TAVI space in this case?
Yes, so let's go now to the popular PAUSE randomized controlled study. This is yet another trial designed by our friend Joost from Mieghem. And again, he has found the formula to publish in the New England Journal, right? So the popular series has been extended now with this randomized controlled study looking at patients with predominantly atrial fibrillation and a need for oral anticoagulant drug therapy who are also undergoing TAVI. And then the question is, should you interrupt the oral anticoagulant drug, or is it okay to continue this oral therapy around the procedure? Well, the mean age of the patients was 81 years old, 1/3 were women, 95% had atrial fibrillation, the remainder had some venous thrombosis issues, and 81% were on a non-vitamin K oral anticoagulant drug. Patients were randomized 1-to-1 to periprocedural continuation or interruption of the oral anticoagulant drug. And the primary outcome was a composite of death from cardiovascular causes, stroke from any cause, myocardial infarction, major vascular complications, or major bleeding within 30 days after TAVI. A primary outcome event occurred in 16% in the continuation group and 14% in the interruption group. And this was not significant for non-inferiority, so not non-inferior. So basically, there was no difference in thromboembolic events between the two treatment strategies. It was 8 versus 9%, but there were more bleedings. 1 in 3 of the patients in the continuation group versus 1 in 5 of the patients in the interruption group. And these bleedings were not the very life-threatening bleedings. Those were the bleedings that were deemed clinically significant, but predominantly were bleedings that required prolonged manual compression, stuff like that. So I think the simple message of that trial is that if a patient is on oral anticoagulant drug therapy before TAVI, why would you not interrupt it for 1 or 2 days? It will not harm the patient. As a matter of fact, it will make your life and also the patient's life easier in terms of a reduction in minor bleedings. Yeah. Why argue with that? I mean, we're talking about a treatment that still requires large bore arteriotomy access. It's different from a venous approach, for instance, in AF ablation, where continuation of oral anticoagulant drug therapy makes total sense. This is a different story. I would still, in my practice, interrupt it and do the TAVI and then restart after.
Yeah, a clear message. And this was obviously a little bit as anticipated. Yeah. But I think this is now finally a proper trial that proves the concept. It can be continued, but better to stop, and you improve your safety.
Yeah, but yet another very practical study by Joost presented, and first author Dirk-Jan van Ginkel. Very good work. Okay, let's go to the Notion 3, and Notion is also on a series in the New England. We had Notion 2 a couple of months ago. This time Notion 3 was presented at ESC and also published simultaneously in the New England Journal. The question was, in patients with aortic stenosis and coronary artery disease, significant coronary artery disease, that was defined as either a positive coronary physiology assessment or a significant stenosis more than 90%, so almost critical coronary lesions. Well, do you need to treat these lesions, or can you just focus on the aortic stenosis and that's it? 454 patients were enrolled. The trial started in 2017, was ended in 2022. The mean age 82 years old, mean STS score 3%, median follow-up 2 years. 40% of the patients received a balloon expandable valve, the others a self-expanding system. The median syntax score, only 9. So not very extensive, complex coronary artery disease, and most lesions had a stenosis of more than 90%. So again, patients were randomized to TAVI with PCI or TAVI and no PCI. And the PCI could be done before, in the majority of cases was done before the TAVI procedure, 74%, and 17% was done concomitantly during the TAVI procedure, and in 9%, the PCI was performed after TAVI. The primary endpoint, all-cause mortality, myocardial infarction, or urgent PCI at 1 year. Well, this occurred in 26% in the PCI group versus 36% in the conservative treatment group. And this was significant in favor of the PCI treatment arm. The incidence of myocardial infarctions doubled, 7% in the treatment arm versus 14% in the patients that were not treated for their coronary disease. And the need for revascularization, 1 in 5 of the patients in the control arm versus only 3% of the patients who had a PCI done around the TAVI procedure. A bleeding event occurred in 28% in the PCI group and 20% in the conservative treatment group. That was somewhat higher in the PCI group, but obviously the benefits of the revascularization outweighed this minor increase in bleeding complications. And by the way, only 3% of the patients in the PCI arm had PCI procedure-related complications. So this is very important data in my opinion. Again, very practical, because we obviously see a lot of patients with aortic stenosis and coronary artery disease. 50% or higher have coronary artery disease. And we did not have a positive randomized controlled trial. As a matter of fact, we had one other randomized study from the UK that was a negative study. Mean age of those patients was 83 years old. Their STS score was somewhat similar, but this study had a slow enrollment and was terminated prematurely. But this was also a different era of TAVI. Now, that was enrolling patients in 2012 to 2019. This Notion 3 was enrolling patients between 2017 and 2022. Well, TAVI has evolved dramatically over the last 10 years, but also the patient selection. And I think the more fit the patient, the more active the patient, the higher the likelihood that PCI will benefit the patient. So I think this is an important difference between the two trials. And also the endpoint in Notion 3 was at 2 years, and it was at 1 year in activation. So I think for me, and I'm curious to what you will say, Joost, but I would have a low threshold to treat concomitant coronary artery disease, significant concomitant coronary artery disease in patients who need also a TAVI.
Yeah, obviously this is a topic this has been a topic of debate since day one we do TAVIs, right? And I mean, there's up until now, there was no evidence supporting the use of a liberal use of PCI in those patients. That said, exactly this strategy is exactly what we have been doing since day one, and also in terms of timing of the PCI, most PCIs were done pre-procedurally. So this is something that reflects our practice, and it's good to see that it's now something that is really also supported by evidence. And as you say, I think this is something that will become more and more important once patients start to become younger, lower risk, etc. My only comment would be that 21% of revascularization rate in these 83-year-old patients who were not treated, I think it's substantial. So I'm not sure whether there was any bias of knowing that you have a lesion that was not treated, but that said, I think a nice trial that will have impact.
Well, yes, but still, I was expecting an underpowered trial. And I didn't expect this magnitude of an effect, but okay, we have it now, and I think it makes total sense. And now the question becomes, okay, but when would you need to do the revascularization, before or after the TAVI? And this is the topic of another ongoing randomized controlled study. For instance, the TAVI PCI study from our friends in Zurich, and we are also collaborators, is exactly looking at that. So Do you need to revascularize before the TAVI procedure, or do you need to do it after? Well, stay tuned in the following years. Well, we also have the RHEIA trial. Briefly, this was a study focusing on women. So only women were eligible for this study. Patients were otherwise all comers, and they were randomized to TAVI versus surgery. 443 women were enrolled. The mean age was 73 years old. The STS score was around 2%. 48 sites participated in 12 European countries. Patients were randomized to either surgery, surgical bioprosthesis, or TAVI with the balloon expandable SAPIEN system. The primary endpoint was a composite of all-cause death, stroke, and rehospitalization. And as expected, TAVI outperformed surgery. It was not only non-inferior, it was also superior, and this was driven by more rehospitalizations with surgery, 11% versus 4.8%. There was no difference in mortality or stroke, but there was a big difference in hospital stay. So patients were staying much longer in hospital after surgery, 9 days versus 4 days. And in our practice, it's even less these days after a TAVI procedure. And then as expected, new pacemakers were somewhat higher in the TAVI arm, but still in the single digits. This is important. And mild PVL was more common in the TAVI arm. But yeah, you may ask yourself, is this clinically relevant? At least not at 1 year. And the question is mild PVL important and has it an effect on long-term mortality? Probably not. As far as we know, we have 5-year data from other pivotal trials comparing TAVI versus surgery, Notion out to 10 years. There is no penalty for mild PVL. And I think the important conclusion of Hélène Elchaninov was, well, TAVI should be the way to go for elderly women with severe aortic stenosis, regardless of the operative risk. Why? Because, well, first of all, you will have less rehospitalizations and you will dramatically reduce the use of healthcare resources.
So that wraps up our wrap-up of ESC 2024.
Yes, obviously there was much more science presented in the heart failure setting. There was also an interesting trial on beta blockers. There was an interesting study evaluation on cardiogenic shock and the change in shock stage over time, within 24 hours even. We may consider to do a part 2, but for now, thank you for your attention. Stay well, and we'll see you for sure for the preview of the upcoming TCT.
Thank you. Bye-bye.
Bye.